Can you guys see my screen now?
Yeah.
Okay. I'm not sure we talked about this Jarixexima reaction yesterday. So it was removed. Guys, there should be a reaction that should be somewhere here. Hello? Can you guys hear me?
For syphilis, right?
Yeah, for all those treponema,
After
for all
the
those
use of
spirochetes.
penicillin.
It's not only for syphilis, all those
Okay.
spirochetes.
But
Yeah. So maybe leptospira, Borrelia or syphilis, but commonly syphilis. But it could be any one of them. So they removed it. So I don't know why they removed it. Maybe they don't want to test questions, on it again, or they just decide to remove it because it's irrelevant. I don't know why. So that one is their own headache. But it's still good for you guys to know it that there's this Jerichima reaction that happens when you commence within like 24 hours when you commence medication to treat any of those spirochete infection, which includes Borrelia, Leptospira, as well as Treponema. So it usually presents as fever, chills, rigor, as if somebody has how do I put it now? More like
I think we
a
talked about
fever.
it at some point in it, at one particular part.
eh,
We talked about it.
okay, maybe you
Yes.
just
But it's
mentioned
just
it.
that they didn't put it under, yeah.
Okay. Oh, okay. Yeah. So then tachycardia like potential. So they are very hypotensive. So because of that, they are going to have reflex tachycardia. So you want to give them aspirin or NSAID to reduce the inflammatory response, and maybe if they need to give fluid, you want to resuscitate them with fluid. So that's that about that. So today we'll start with mycology. So we are done with bacteriology. So we start with the fungi today. So we are going to start with the systemic mycosis. Um, Systemic mycosis, that means systemic fungal infection. We have four of them that we need to pay attention to majorly. I think there are more than four actually, but for the um yeah, the systemic mycosis, there are four that we are going to talk about. So that includes histoplasmosis, blastomycosis, coccidioidomycosis, and paracoccidioidomycosis. Yeah. So they have some similarities. All of them can cause pneumonia. So pneumonia is even a starting presentation for all of these guys. They cause inflammatory lung disease. That's one thing. Another thing is they can disseminate from the lungs, get to the blood, and travel to other organs, especially in the people that are immunosuppressed. That is another fact. These four guys are dimorphic. That is, they can exist in yeast form and they can exist in mold form. So mood form, the way I just simply learned, those two presentation is that the mode form is the one that is filamentous, and you typically have that form outside the host, that is within the environment, maybe the soil, um, organic matter, any area where they are, and the temperature where you have the mold is very cold. It's cold, like 20 degrees Celsius. For example, you have the mold in the soil, buried deep down in the soil that is cold, 20 degrees Celsius. So from the name, you can even master it. So mold, cold, 20 degree. Why the yeast form? The yeast form is the one that you typically have in the host. For example, human. And that one exists in an environment of higher temperature relative to the mold form. So the temperature for the yeast form is 37 degrees Celsius. That's like, normal body temperature of human. So we have to pay attention to that. Yeast form 37 degrees Celsius. Cold. The mold form is cold 20 degrees Celsius. There's an exception, and Candida is the only exception to this rule. We are going to talk about it. Yeah. So out of these four guys, coccidioidomycosis or um, Coccidioides, which is the organism that causes it. So Coccidioides immitis is what causes coccidioidomycosis. When it colonizes the host, it doesn't exist as a yeast. Outside, it can exist as a mold, but when it gets inside, it doesn't typically form the yeast that other organism forms. It exists as what we call spheral. So you are always watching out for this statement in your question. Once you see spheral, your answer is coccidioidosis or coccidioidomycosis. That's what you are looking out for. It is the only fungi, the only systemic fungi that can, you know, form spheral. And what is that spheral? You guys can see the image. That's image D. Can you guys see image D?
Yes.
Yeah. So that spheral is just like a ball of cells. So the spheral contains what we call endospore. Those endospore are these tiny, tiny balls, these reddish things that we can see. So the spheral contains the endospore. The endospore can break out to form the original microbe, which is the coccidioidomycosis, the coccidioides. So they can form the coccidioides. So they are like progeny to the coccidioides, those endospore that are within the spheral. So spheral just like the ball, the whole container that is containing those tiny, tiny endospores. So the endospore can germinate into the coccidioides organism that can now cause infection. So they can colonize a lung, form this colony of spheral. Then the spheral can rupture and release those endospores. So they can go to adjacent area of the lung, start the process all over again, or they can disseminate to the blood and cause extrapulmonary symptoms. These guys also cause granuloma. So they form granuloma too. They form cystatin granuloma, just like tuberculosis. But they cannot be transmitted from person to person. No, that's not it. It's not. They are not infectious. You don't transmit them from one person to another. No, you have to get them from the external environment where the spore are located. So you have to inhale the spore into the airway. Then you start. That's why we said the initial presentation is actually like an inflammatory lung disease or pneumonia. So you have to inhale the spore from the environment. The disease process starts like pneumonia. So you don't spread it from one person to another person by spreading the aerosol droplet or something. No, it doesn't work that way. You have to get it from the environment yourself. So what is the treatment modality? Of course, we have not gotten to pharmacology section yet, so we might just need to memorize some of these treatments for now. But one thing I'll just say is that majority of the local infection, you treat them with the azoles. What are these azoles? Fluconazole or itraconazole. I know that this is not the first time we are hearing them. So azoles majorly most of the time local infection, fluconazole, itraconazole. If you want to step higher, you want to take care of something that is more systemic, something that is more disseminated, something that is more severe, you want to use amphotericin B. So amphotericin B is one of those powerful antifungal that you can use for systemic infection. Another one is echinocandin. Echinocandin too is very powerful for systemic problems. But for localized issue, just stick with the azoles for now. You can also use azoles for systemic, but they are more reserved for local infection. So fluconazole, itraconazole is one of them. So let us go to the clincher for each of these guys. So let's start with histoplasmosis. Histoplasmosis is also known as Ohio River disease or cave disease. So I think we've seen a question on this before. So from the name, you can know, you know, how the question can go. So once you start seeing something like cave exploration, you know, they are painting the location to be at the setting of maybe Mississippi or Ohio. So that Ohio one should, really stick. So Ohio Valley. So Ohio Valley or cave exploration, that's likely to be histoplasmosis that they are talking about. How do they get this histoplasmosis infection? So um, bat or bird have their droppings, containing these histoplasma spores. So the spores are within the bat and the bird droppings, and it's been deposited within caves because Some of these bats, this bird, they live in caves. So caves within Mississippi and Ohio. So if somebody goes to that cave to explore it and they kind of inhale those spores from the caves, they can develop histoplasmosis, particularly pulmonary histoplasmosis. That's the first presentation. The alveolar macrophages are the first immune cell that is going to respond to the spores. So they try to engulf the histoplasma organism from the spores because you are going to have the organism being released from it. It's going to germinate out of the spores in yeast form now. So it's going to be in yeast form because it has gotten into the host. So replication will occur within the macrophages. They can rupture and kill off the macrophages and disseminate elsewhere depending on the immune status of the individual. So if the person is very immune, the macrophages can confine rather the organism, and it doesn't proliferate, replicate, and kill off the macrophages. So it becomes dormant in that kind of person and they will be asymptomatic. But some people may be immunosuppressed, so the macrophages are not very strong enough to contain the histoplasma organism. They can replicate, cause pulmonary histoplasmosis, and other extrapulmonary infections. So, what are the typical um, um, presentations that you can see someone that has histoplasmosis? So, they can have pulmonary histoplasmosis. That's the first one. It's not mentioned here because that is what you expect for all of them. It's common to all of them, pulmonary symptoms. So, they can have pneumonia. Then you have some specific. So, histoplasma can disseminate into the once it disseminates into the blood, it can travel to the liver, it can affect the spleen, so they can have hepatosplenomegaly. It can affect the bone marrow, causing pancytopenia. Another thing that we should also remember about this histoplasma is that it's one of the causes of erythema nodosum. So erythema nodosum, the way they usually describe it, they will say tender, raised, lesion within the legs or anterior aspect of the legs, the shin. That is likely to be erythema nodosum. Once you are seeing tenderness, you should you should um you should have erythema nodosum at the back of your mind. If it's not tilting towards the hepatitis epitiformis, which can be painful too, can be itchy, and that one will be vesicular most of the time. But if they are saying maybe a macule or maybe purple that is tender and is located in the lower extremity, it's likely to be erythema nodosum. So histoplasmosis can cause erythema nodosum. It can affect the liver. It can affect the spleen, it can affect the bone marrow, then it can cause ulcers within the mouth, oropharyngeal ulcers. So they can have palatal ulcers within the buccal, palatal ulcers within the palate. They can have ulcers within the buccal region. They can even have ulcers in their tongue. It's good to remember all those ones. But the major thing that will help you, number one, the location. Number two, the environment, caves, cave exploration. Then the pathological feature. So you tend to see it within the macrophage. So they are filled within the macrophages and they appear smaller than the red blood cell. So they are comparing the size of the organism to the size of a normal red blood cell. I think normal red blood cell is about 7 micrometer, but your osteoplasma organism is smaller than that. Once you do the blood smear, you can see the organism within your your macrophages and they appear smaller compared to the size of your red blood cell. So you can see an image like that, which is here. So these are the histoplasma organisms, are this tiny, small, round organism beside the within the macrophages. So you can see the nucleus of the macrophages. Yeah. So that is that about histoplasma. You guys should not worry about yourself about the diagnosis. You can do antigen or urine antigen test. So serum or urine antigen test. It's not really how they rarely ask that. So most of the time they will ask you to make a diagnosis. The second one is blastomycosis. Um, it might be very difficult to remember the location for the blastomycosis, which is at the eastern or the central US, because we don't know the geography of the US, so we don't know the states that fall in that area, and we can't be memorizing them. But what will help you make diagnosis of blastomycosis is when you see broad-based budding. It is only blastomycosis that forms broad-based budding. It is only blastomycosis. So what they mean by the broad-based budding is the daughter cells that are branching off from the mother cells are looking like the mother cells, like apparently like the same size, almost the same size. So you guys can see the way it looks like here. So this the daughter cell branching from the mother cell. So they form this broad base appearance. So from the name blasto, so B, blasto, blastomycosis, broad based budding. That is blastomycosis. For you will always see this pathological feature in the question. It will always be there. So once you see it, you know your diagnosis. How will somebody with blastomycosis present? Its own presentation is quite different from that of histoplasmosis. It will cause the normal lung disease, which is the inflammatory lung disease. That one is normal. In people that are immunocompromised, it can disseminate to two areas. Majorly, it can disseminate to three areas. Majorly, three areas. Can go to the bone, can go to the skin, can go to the brain. So sometimes they might bring a scenario of somebody having neurological manifestation from this blastomycosis, and you'll be tilting. They want to tilt your mind towards um, cryptococcus. No. Sometimes you want to calm down and read through the question to look for clinchers. So once you are seeing neurological presentation and you are seeing from your pathological feature, you are seeing broad-based budding, you know that is blastomycosis. So they can go to the brain, cause brain abscess, even cause meningitis. It's not uncommon. They can disseminate to the bone, but when they get to the bone, they cause very chronic damage to the bone. It can cause osteomyelitis to the bone. They go to the skin too, they cause very chronic problem in the skin. The skin manifestation can be in form of verrucous or warty-like lesion, or they can just cause ulcer. So we can see here, this is the ulcer form we are seeing here. So they can form very chronic debilitating ulcers in the extremities or the part of the area where they are affected. Sometimes it might just be taking appearance of a wart. So you want to have that in the back of your mind. Once you are seeing ulcers, you know, or verrucous lesion in the skin, warty-like lesion in the skin, osteomyelitis, inflammatory lung disease, or cerebral affectation, brain affectation with broad-based budding, blastomycosis. So blasto can go to the bone, B, it can go to the brain, the second B. Then it can go to the skin. So that is the one that will cause terrible ulcers. Terrible ulcers. It will blast the leg, you know, and it will, form these terrible ulcers. Blastomycosis, broad-based. Don't forget that. The next one is the coccidioidomycosis. We've talked about this forming the spherules. So once you see the question telling you they are seeing spherules, they will always mention all these pathology. They are not that stingy. They will always mention them. So that is why that is even the most important thing to pay attention to. So what am I going to see for histoplasma? Macrophages engulfing the yeast of the histoplasma, and they are smaller compared to the size of the red blood cell. You know what they are talking about. You are going to see a cave, you are going to see Mississippi location or the Ohio River Valley location. You know that is your histoplasmosis. You want to look for the clinchers. Is this person having erythema nodosum, any rash, any splenomegaly, hepatomegaly, any ulcers in the mouth, in the palate? That can help you. Blastomycosis, broad-based budding, presentation, bone presentation, stomatitis, skin presentation, chronic ulcers, brain presentation, maybe meningitis-like symptoms, lung presentation, inflammatory lung disease causing pneumonia, broad-based body. Your coccidioidomycosis, you are looking for your spherules. So spherules, like a ball containing numerous endospores. So the tiny, tiny spores within them, those are the endospores that can rupture and form and release the coccidioides organisms. These ones are much larger than the iris, of course. The endospore itself, the spherule rather, the spherules are much larger than, you can see it's a big ball containing all these endospores. So it has a larger appearance compared to the red blood cell. So if you obtain maybe a bronchoalveolar lavage or you induce a sputum from this patient and you stain it, maybe by periodic acid Schniff stain, you can see this. You can use your silver methanamine stain. You are going to see this spherule. Any stain you want to use, you are definitely going to see this spherule. So you see it when you do your culture, you see it when you do your cytology, your histology, they are there. How will they present? So its presentation is very similar to blastomycosis. They are like this. Once you remember blasto, you remember your coccidioidomycosis. It goes to the lung initially, Just like blastomycosis, it goes to the bone, it goes to the skin, it goes to the brain. That is it. The same thing, the same, organs, the same thing. So if it goes to the bone, what does it cause? It can cause arthralgia. It can cause osteomyelitis too, but it has a triad. I think I'm supposed to start with the triad. So there's something we call desert rheumatism. So this coccidioidomycosis is typically found in the desert of states within the southwestern region of US and California. If you remember, this is good, but I'm very, very sure that they will always talk about this ferrule that will actually help you narrow down your answer to your coccidioidomycosis. So what are these triads? The triad is called the desert rheumatism. The way I learned it is that desert rheumatism, one thing I know about rheumatic fever is that there's a fever, there's a joint problem, and there's a skin rash. So the same thing applies here. Desert rheumatism of coccidioidomycosis. There's a fever, of course, there's an infection. There's this rash, but what is this rash? This rash can either be erythema nodosum or erythema multiforme. So we already said yesterday that erythema multiforme can start as a red patch and later transform into the target lesion. And Dr. Francois mentioned that one of those clinchers that you can use to separate it from um, erythema migrans is that they will tell you that the multiforme one, the migrants migrate. So it's appearing in one area now, then going to another area. So once you see that, you can narrow your lesion to erythema migrans. Most situations of erythema multiforme, they will start together. So you won't see any migrating lesion. So once you see migrating targeted bullseye lesion, that's likely to be erythema migrans. And that is peculiar to Lyme disease. But here, we're talking about erythema nodosum, which is also found in someone that has histoplasmosis, and erythema multiforme. So the last one is now the joint issue. So they can have arthralgia. So that's a triad for coccidioidomycosis. It can also go to the brain and cause meningitis, just like blastomycosis, particularly in people that are immunosuppressed. But this one is not typically, it's seen in caves. It's in desert. So you can have earthquakes in desert. Those earthquakes can actually blow the soil to other areas. So and those soil, they contain the spore of the fungi. So people can inhale the spore and they can develop it. Or people that go about doing archaeological excavation, maybe they are trying to explore for some ancient bones or something. In the process, they can go to the desert and they can inhale the spores and they can get the condition. That is that. Once you know desert rheumatism, you are okay. You have already palmed everything. So your rash is erythema nodosum or the multiforme. There's a fever and there's arthralgia. So you are home and dry. Okay. So the last one, para coccidioidomycosis. So don't this one too is similar to blastomycosis, yeah, but once because blastomycosis itself is also similar to coccidioidomycosis, so you can say that coccidioidomycosis is like the same thing as paracoccidioidomycosis. That is it, but it's common in males compared to female, and you typically find it in Latin America. So if you go to all those um America those Latin America area, like maybe like Argentina, South American countries, they can get exposed to paracoccidioidomycosis. The clincher for this one is just you are going to see budding yeast that has a captain wheel appearance. So once you see captain wheel, you can see. You guys know the wheels of sheep. You guys remember the way it looks like. Do you guys know the way the sheep wheels looks like? Guys, hello? Hello, can you guys hear me? Hello?
Oh, yes.
Hello? Oh my god. Is it my network? Okay.
Can you?
Okay, thank you, Dr.
Okay.
Bisola. Yeah. But even I'm trying to send a message to the group now, it's not even going. Okay, okay. Thank you, thank you, thank you guys. Thank you. Okay,
We
so
can.
yeah, so once you see the captain wheel appearance of your the budding yeast, so you can see the yeast make forming buds that have the captain wheel appearance. You know that is paracoccidioidomycosis. So the presentation is not different from the blastomycosis, is not different from coccidioidomycosis. They are similar. So I think with this point we can differentiate between those guys very well. So by the time we are looking at questions, it will be very easy for us. So let's talk about the opportunistic fungal infection. So the opportunistic fungal infections that we are going to talk about is four or two, and we are familiar with some of them already. Candida albicans is the first. So Candida white from the name. Alba means white, so it's whitish colored organism in terms of its presentation. So it causes whitish lesions. It's dimorphic, that is, it can exist as the mold and the yeast, but it is only Candida that doesn't follow the normal temperature of the mold, the yeast. So we expect the mold to be existing in a cold region deep down in the soil, about 20 degrees Celsius, and the yeast should be, in the host at temperature of about 37. So reverse is the case for Candida. So the mold form of Candida exists as what we call germ tubes. So jam tubes are just like straight tubes. So I just don't want you guys to bother yourself. Once you just see image B, a straight tube without any constriction, that just contains a cap. That's your jam tube. It's like a straight tube. It's a single tube. It's a single tube. You know, that's your jam tube. It has no constriction. Everything is just straight. It's just straight and parallel. There's no constriction and it has a single cap. That's your jam tube. So that is the mode form of. So this guy is going to differentiate into the mode for Candida. So that's that. And you typically see it um at 37 degrees Celsius. So opposite of what you should be normally with respect to other organisms. So that is the germ tube. Then the yeast form of Candida. Sorry guys, sorry about this guys. Sorry. Yeah. So the yeast form, forms pseudo hyphae. So normally you should not find pseudo hyphae in the yeast. So the yeast should not be forming bud. You guys remember the para coccidioidomycosis I've talked about now, captain wheel, bud of the yeast. Then we talked about the blastomycosis having a broad-based yeast. You know, that's the way it should be, broad-based budding of the yeast. But the yeast of Candida has pseudo hyphae. So that's why they call it pseudo hyphae, because it should not be there. They have a false hyphae. And that hyphae is looking like the hyphae of the jam too, but it's having some constriction. So I don't know if this image is actually very good. You can only appreciate the constriction when you look at your own book. So you just see some interruptions. That's the meaning of the constriction. So you can see one constriction here, there's one constriction here, there's another one here. So then you can see the buds, on top of it, multiple buds. So
Mm.
that's the way. Once you see like multiple buds, on a stick, don't think too much. You cannot have the jam tube being multiple like this. They will usually show you a single image. But once you are seeing
Mhm.
multiple buds and you are looking at the stick is having some constriction, you know that this is your pseudo hyphae and the bud of the yeast. So this is the yeast form of Candida. This is what you see for the yeast form of Candida. I see this at the cold temperature. Yeah. So which is 20 degrees Celsius. So Candida can form systemic and superficial infection. Superficial infection, that is affection of the skin and the mucous membrane. Systemic is now when it gets disseminated and travel to the organs. So what are the superficial infection that we should pay attention? It can cause skin infection. Skin infection, like just on the skin, it can just cause some erythema, some scaling, whitish lesion there. You know, It can cause infection within the diaper area, which we call the diaper rash in babies. So Candida is one of the implicating organisms causing diaper rash. That's an example of a skin infection. Hello?
Sorry to take you back a little. Yeah, sorry.
Okay.
I just kind of think I missed it up. You said the studio IFA is the one that forms the mold at 37, and the body yeast is the one that is 20 degrees Celsius, Sabi?
Please come again with the question. Let
Did
me
I
process
mix
it.
up?
I think you have mixed it up. But come again. Let's
So you said
iron it out. Okay. I'm listening.
like the studio IFA is the one like the mold at like 37 degrees Celsius, and the body yeast is the one that is at 20 degrees Celsius, Abi? Did I mix it up?
Sorry, doctor. Zulia, I did not hear you. Sorry for the last time. Please, I'm sorry. Oh yeah.
Okay, so what I was asking is, I know you were differentiating the yeast and the mold form. Like you said that the pseudo IFA, what's it called? Is not supposed to be giving us what's it called? Is it the burden or something? And you were like at 37 degrees Celsius. So I'm saying that is the pseudo IFA is one that is giving more 37 degrees
Okay. So let
Celsius,
me
and the
take it
body is
again.
one that is
Let me take it again. So you know that the typical temperature where you should form mold is what?
at
20. Yes, cold. So the temperature where you should form the yeast is 37,
20.
right? Do you hear me now? Do you get it now, Dr. Zuliat? Hello? Are you
Hello,
getting it?
what?
Are you
I
getting
don't.
it?
I
The
think. Hello. No. You are now.
the network is
Hello.
messing with me seriously. Oh my god. So I said that the
Maybe
the
on WhatsApp.
eh let me try one more time. So I said the mold exists in cold temperature 20 degree. The yeast exists in 37 degree, which is warm. Did you get that, Dr. Zuliat?
Yes.
So the reverse happens for
That's like
Candida.
normally, Abby.
Yes, that is normal.
Mm-hmm.
So the reverse happens for Candida. The mold form of Candida is in 37, while the yeast form is in 20. That is settled. Now, the mold form of Candida is the germ tube. The germ tubes are filamentous. They
Okay.
can form filament. So the typical thing about the mold is that they have filament. So germ tubes can germinate into the mold, which will have filament. These filaments are
Okay.
yeah. So once you have the fungal form that is filamentous, you call it the mold. So this germ tube, the way they describe the germ tube is that they have non-constriction within their walls. So there's no constriction within the walls. No constriction within the
Okay.
walls. That's the germ tube. And that is the mold form. So that's the mold form. The mold also contains hyphae. So the filaments are the hyphae. Do you understand, Dr. Zuliat? The filament of the mold are the hyphae. Are you getting it?
Okay.
Hello? Yeah. So you should not have hyphae
Yes,
in the
I'm
yeast.
getting you.
Yeah. So we should not have hyphae in the yeast. Yeast doesn't contain filament. They are non-filamentous. They are non-filamentous form of the fungi. They should not contain hyphae. They should only contain buds. This bud, that's the only thing yeast has. They just bud. That's the way they divide. Binary division, forming buds.
Okay.
But the yeast of Candida, in addition to having the buds, they also form pseudo hyphae because hyphae is not peculiar to yeast. That's why we are calling it pseudo hyphae. You get it? Hello? So Dr. Zulia,
Yes,
do you
it's
get do you get it now?
well. Yes, yes, yes. I've
In fact,
gotten it. Yes.
I'm so scared because of this network. I don't know what is wrong with MTN in my area. It's terrible. We are just dealing with light, just dealing with uh what's it called? What's the other one too? After light, what's the other network? Network is just I don't know, it's just embarrassing. And that's another signal to me that I have to leave this country ASAP. Dr. Zuliat, come and take me out of this country
Mm.
now. Hmm? Dr. Zuliat,
I'll be
ẹ jẹ́ kí n wá
coming now.
ẹ jẹ́ kí n wá fara mọ́ yín díẹ̀ ńbẹ̀ yẹn. Look at the way I'm suffering.
Uh-uh.
Eh? Look at, just imagine. It's too
Go on,
bad.
Lekwete.
And you said we should vote for Tinubu. Now we voted for Tinubu. Now we okay. So let's just that one is by the way. That one is by the way. So you know. So what are the infections that you expect from Candida? Systemic and superficial. So the superficial one are the skin and the mucous membrane. So they can cause skin infection. They can cause some of those skin infection include diaper rash in babies. So once you see diaper rash in babies, you are thinking of Candida. Diaper rash. You open the diaper, they are seeing those erythematous lesion, particularly within the intratriginous areas, in between the thighs of the baby, diaper area. That is Candida. Candida is one of the implicated organisms causing that. Um, they can cause chronic mucocutaneous candidiasis, which is like a form of candida affecting the skin as well as the mucous membrane. In addition to the skin appendages like the nail, so they can cause onychomycosis, they can cause dermatitis, the skin itself and the mucous membrane. So we call it chronic because it occurs for a long time and it doesn't typically respond to medication. So this one typically occurs in people that have T cell deficiency. So there's when there's any problem cellular
Efficiency.
with the cellular harm of the immunity, the T cell area is affected. You start having this infection. So when there's any problem with the cellular mediated or cell mediated immunity, the person can develop chronic mucocutaneous candidiasis. So affectation of the skin, the mucous membrane, as well as um the nails. So yeah, so that is that about the mucocutaneous. So when we are saying the mucous membrane, we are looking at the membrane of the esophagus, the oral mucosa, the vaginal mucosa. So all those forms are form of mucous membrane affectation of candida. So the mucous membrane includes the mucous membrane of the oral cavity, the esophageal lining, as well as the vagina. So it can cause oral and esophageal thrush, which is the mucous membrane affectation, particularly in people that are immunosuppressed. So once you are seeing somebody having oral or esophageal candidiasis, you want to check their immunity. Very important because most of the time they will be immunosuppressed, either from the use of steroids, from diabetes, or from HIV/AIDS. In neonates too, because in neonates they are just developing the white blood cells, so they can be predisposed to developing oral or esophageal candidiasis. So that's a form of um, mucous membrane affectation of candidiasis. So another one is vulvovaginitis, can affect the mucous membrane of the vagina. So people that are using a lot of antibiotics, over abuse of antibiotics can disturb the flora of the vagina, and you can have proliferation of the candida, because candida is also one of those organisms that are there. So and candida is not a bacteria. So candida will not respond to antibiotics. So it will kill off all the antibiotics that are existing as normal flora, leading to unrestrained proliferation of the candida that can cause vulvovaginitis. And we've talked about the way candida vulvovaginitis will present. People that are diabetic too are predisposed to developing vulvovaginitis from candidal infection. We've mentioned it that um, people that take IV medication can have IV medication or uh, injection mediated form of infective endocarditis. So the one that affect the tricuspid valve.
That's when the conductives.
So I will mention some organisms. We said Candida is one of them. Pseudomonas
Yeah.
typhi, Staph aureus is
Right.
so that's a systemic form of Candida. So when it gets to the heart, it can cause infective endocarditis, and that's a systemic form. You can have the disseminated form, particularly in people that are neutropenic. This stuff is very important. This is tough. Once you can say this, you have tough. Disseminated candidiasis occurring in people that are neutropenic is not common stuff. So it's not only T cell. T cell immunity can just make them have the affectation of the mucous membrane, affectation of the skin, causing chronic mucocutaneous candidiasis. That's like a localized form. When it disseminates into the bloodstream, that's enter the bloodstream, affected so many organ systems, the liver, the spleen, the brain, the joint. you call that disseminated candidiasis, and it is very common in people that are neutropenic. So you want to check the neutrophil count in people with disseminated candidiasis. Please don't fall for T cells. It will not be T cells. It will be neutrophil count. If it's localized, T cells. Localized and chronic, T cells. Disseminated, neutropenic people. Very important. So how do you treat? So if you want to treat someone that has vaginal candidiasis, vaginitis from candidal infection, you want to give them the topical or oral fluconazole. So you just give them topical azoles, any of the azoles, or you give them oral fluconazole, just like we've mentioned. So something that is, still localized in vagina, you just want to give them topical azole or the oral fluconazole. If you want to treat someone that has the oral thrush, one of the antifungal that you must always remember that is swallowed orally is nystatin. So okay, like before I start, just know that the azoles can work for all of them, all the treatment forms. You can give azole, so that one is settled. If you want to treat the oral, you can give the azole, that's already there. Then you can use nystatin. This nystatin is majorly taken orally, so it can help with the oral candidiasis. Nystatin, don't forget that nystatin, or rarely echinocandin. That was why you might not remember. Don't even put your mind there. Just remember your azoles and your nystatin for the oral.
Okay.
Vaginal topical azoles. Then the last one, which is the esophageal and systemic. So they are classifying esophageal and systemic um, candidiasis together. So it's more like before you can have that esophageal candidiasis, the person white blood cell count will have dropped so severely that you need something strong. Yeah, you need something strong for someone to have esophageal candidiasis. I can't remember the precise white blood cell count now, but I know that it's low. It's very low, much more than the oral one. So you want to use something strong. And we said one of the strong medication that you can use for systemic one is what? Anybody remember that strong medication that we said we can use for systemic?
Wow. So amphotericin.
Exactly. So
You
amphotericin B.
mentioned amphotericin B.
Yes, amphotericin B, very important. So you remember your amphotericin B first. Your amphotericin B can work for esophageal and systemic because esophageal is more like it's getting very severe. So like systemic. So you want to use the same medication. After amphotericin B, the next line in command is your echinocandin. So your echinocandin and your amphotericin B, both of them systemic. Echinocandin and amphotericin B. Then of course we've said that the azoles can work for the three, both your oral, both your systemic and your vaginal. So you give your fluconazole for that too. It can help with that. That's all about candidiasis. So just remember, the way to just remember the candidiasis is separate them. Skin, mucous membrane, disseminated. Skin, mucous membrane, disseminated. So what's the skin? It can affect the skin. It can cause like diaper rash. So the mucous membrane of the mouth and the esophagus. So they can cause oral thrush, esophageal thrush. Yeah. Disseminated. It has gotten to the blood and travel everywhere. So it can find its way to the lungs, to the heart rather. They can even cause lung issues too, but we just classify that as disseminated form. So it can go to the heart particularly and cause infective endocarditis. It can go to other organs like the liver, the lungs, the spleen in the disseminated form. Then we can have a form that is chronically affecting both the mucous membrane and the skin, which is a chronic mucocutaneous form that we said is highly common in people that are having problem with the cellular arm of the immune system. And we also said disseminated candidiasis typically occur in people that are neutropenic. Someone that have the vaginal problem, which is one of the mucosa that I've not talked about that I forgot to mention, is people that are diabetic or people that are using antibiotics too much. Candida vaginitis. People that are having the oral or the um, esophageal thrush. They are people that are immunocompromised. So oral and esophageal thrush is one of those aid defining, illness of a team. You guys remember, oral and esophageal thrush is one of them, depending on the stage. Don't forget. So, Aspergillus fumigatus. How you identify Aspergillus is very simple. I think Aspergillus is the simplest. You cannot forget it. It's also that it's okay. It's not dimorphic. So It's not dimorphic, but it has the is it only so if it has a septate hyphae, what form do you guys think is existing as? Anybody? Let me just see if you guys are following. So aspergillus exists as an hyphae form. What form do you think is that?
That would be the mole.
The mold. You see that it's very easy. You don't have to cram it. You've already known that mold is the one that have hyphae. So aspergillus is a mold. If you see aspergillus is a yeast somewhere, that is truth. Aspergillus is a mold. It is not dimorphic. It is a mold because it has hyphae. What is peculiar to the hyphae of aspergillus is that it is septated. It has branches. So it has some divisions within the hyphae and it's branched at 45 degrees. Once you see that, that is aspergillus. Very easy to palm. We've seen a question that, they put that description there and we're able to figure it out that is aspergillus. So branch as an acute angle. This is aspergillus. So this is a oral thrush. This is aspergillus. You can see the branching here, branching there. You see the multiple branching like this, branching here, and you can see
Mm.
that the stuff is septated. You have to look at your own image. You'll be seeing some lines there. That's the septa, some lines, some lines. It's not very obvious. But once you see that the stuff is branching, multiple branching, you are not seeing just one branching, no. You are
But
seeing
it's
multiple branching, 45 degree.
multiple.
That's aspergillus. Septated hyphae with multiple branching. That is aspergillus at 45 degree. Aspergillus. Mm? So, what can aspergillus fumigatus cause? It can cause invasive aspergillosis in immunocompromised people. Now, for aspergillus to be causing invasive aspergillosis, most of the time that person will be immunosuppressed. So, will be immunosuppressed, and the person will have chronic granulomatous disease in all the areas of the body where the aspergillus is entering. So the aspergillus normally should just be in the lungs, when they inhale the spore from the outside, the mold from the environment, they inhale it into the lungs, it's being confined within the white blood cells there, they kill it off. But sometimes it can be quiescent there, it's not causing any trouble. But if there's an immunosuppression, it can disseminate from that area and go to the bloodstream and find its way to the other organs. When it gets to those other organs, it will now start chronic granulomatous disease problem. So yeah, particularly people with this neutrophil dysfunction. So people with neutrophil dysfunction that they cannot produce any DPH oxidase. So they are predisposed to developing chronic granulomatous disease from aspergillus. So you see the granuloma in the lungs, you see the granuloma in the spleen, you see the granuloma in the liver, you see the granuloma in the bone. Aspergillus can cause so many things, guys. Aspergillus can cause osteomyelitis. It can cause um it can go to the lungs and cause granulomatous infection in the lungs. It can go to the brain and cause abscess, granulomas everywhere, particularly in people that are immunosuppressed, maybe from neutrophilic dysfunction, of course. So that's one thing you want to watch out for. With respect to this catalase positive organism of a thing, you want to always remember aspergillus. You want to always remember nocardia. Those are the two that they commonly test: nocardia, aspergillus, and I think staph. So you must remember them. So you can have invasive aspergillosis in people that have problems with their neutrophils. So you have chronic granulomatous lesion in almost all the organs. That's invasive aspergillosis. Another thing that can happen with respect to aspergillus infection is formation of aspergillomas. These aspergillomas are just like balls of mold within lung cavities. So they typically follow tuberculous infection. There's a secondary tuberculous disease. It has formed fibrocavitary lesions. There are cavities everywhere. Those cavities are potential needles for our balls of aspergilloma to form. So you just have the aspergillus mold colonizing those areas. You have the worsening of the tuberculosis presentation. You can just have hemoptysis again, serious cough, dyspnea, and other symptoms like that from the aspergilloma. So once you do your imaging, you can appreciate those aspergillomas on imaging. I think we have an image for it. Yeah. So this is the way it looks like. Fantastic. So you see hyperdensities with cavities. Can you guys see this cavity here? Can we see this?
Yes.
So this is a cavity. You could hampered by this hyperdensity. So this is the mode. This is the aspergilloma colonizing that cavity following TB. So once you see a recurrence of something that looks like tuberculosis, and they are asking you what organism do you think is responsible for that, you want to think of aspergilloma. You want to think of Yeah. So that's that about aspergilloma. Then another thing to mention about Aspergillus fumigatus is that it can produce aflatoxin. So aflatoxins are carcinogenic toxin. So these aspergillus guys can colonize or contaminate legumes. So people that eat too much epa, too much groundnut, you can have aspergillus infecting those groundnuts, and those aspergillus can produce aflatoxin. So once the aflatoxin gets into the system, they are carcinogenic. So they induce TP53 mutation, which can drive hepatocellular carcinoma. So that is why aspergillus or aflatoxins particularly is a cause of hepatocellular carcinoma. We don't talk about it, but it's very important. So aside the normal hemochromatosis, the hepatitis infection, the Wilson disease, the non-fatty steatosis or fatty alcoholic steatosis, or even fatty steatosis causing hepatocellular carcinoma. Aflatoxin exposure is also another important cause of hepatocellular carcinoma. And what is the source of this aflatoxin? Aspergillus infection of legumes. Very, very important. Inducing TP53 mutation. We should remember that. We should always remember that. So aflatoxin from the aspergillus contaminating legumes. So it can induce a TP53 mutation leading to hepatocellular carcinoma. So we said three things: invasive aspergillosis. You have chronic granulomatous lesion everywhere, everywhere. In the lungs, in the liver, in the brain. Yes, Dr. Zulia, nice one. In the brain, that's getting invasive. Yeah, especially people that are immunocompromised from neutrophilic dysfunction problem. You can have aspergillomas, which are balls of molds of our aspergillus containing the lung cavities, particularly following tuberculosis infection. Then we're also going to talk about aspergillosis causing hepatocellular carcinoma because they can produce aflatoxin, which can induce TP53 mutation. The last thing to talk about is ABPA. I know we already talked about it. Allergic bronchopulmonary aspergillosis. Once we hear this, the next thing to ask ourselves, does this person have asthma or does this person have cystic fibrosis? Because those are the only two conditions that can make the airway hypersensitive to inhaling the spores of aspergillus. So once you take in the aspergillus spores from the environment, the airway starts reacting to it. So you have your white blood cells, particularly your type 1 hypersensitivity, kicking in. You have your eosinophils, your IgE coming into play, driving the immune response. So this person will present just like someone that has an asthmatic attack. So there'll be cough, there'll be dyspnea, there'll be wheezing, there'll be chest tightness from the hypersensitivity of the airway to the aspergillus spore. So it is heightened. That hypersensitivity is heightened in people that are asthmatic or people that have cystic fibrosis. It can develop and progress to bronchitis. So you can later notice that there will be dilatation of the larger airways with formation of necrotic tissue. So you know that is bronchiectasis setting in. And we know by that time they will start producing this foul smelling discharge, and the cough is going to be very chronic. What are the clinchers for this guy? Yes, Dr. Frank.
Hello, Dr. Mawala.
Yes, I'm listening, Dr. Julia.
Okay.
Dr. Juliet, I'm listening to you.
No, like I couldn't hear you before, so I thought your network has gone. So I was just trying to call you to know whether you are available.
Okay, yeah, I'm still there. Yeah. Okay, so I said that, please, what, I don't know where I stopped though, because I've said some things though.
I mean, we were talking about the allergic BPA, the TH1 eosinophils and all.
Okay.
So
Yeah, the TH2 is the TH2, but it's just type 1,
TH2, so
the type
okay,
1
type 1.
hypersensitivity here.
Okay.
They come in, you have elevation of IgE, eosinophils, they drive the inflammatory response. So I said that they are going to present like someone that has asthma. So there'll be wheezing, there'll be cough, there'll be dyspnea, chest tightness. So particularly in people that are asthmatic or people that have cystic fibrosis. So how do you want to make the diagnosis? You want to the first thing is to do a skin test to um test for aspergillus sensitivity. So you inoculate aspergillus organism subdermally. So if you notice a reaction, you are likely to be dealing with this guy. You do the blood work, you notice there's an elevation of the IgE as well as eosinophilia. It's further in keeping with diagnosis. Then the clinical presentation, so the wheezing, the chest tightness, the cough, helps you to also make the diagnosis. And these guys would likely have one of this background, either asthma or cystic fibrosis. And it can progress to form bronchitis. So when progresses,
Hello, doctor. You stopped talking since you said the skin test. That's Dr.
Doc-
Babali.
Dr. Ziliat, I'm still there. I already knew this thing will happen. It's very terrible. Can you still hear me now?
I can hear you now.
Okay, so I said that, when you do the skin test, you inoculate the aspergillus organism into the skin. Because of the hypersensitivity, they are going to respond to it. Mm? So
Okay.
you can use that. Then if you do the blood work, you are going to see elevation of IgE as well as eosinophils. That's also supportive.
Okay.
Then the clinical
Okay.
presentation, just like asthma, cough, wheezing, chest tightness, dyspnea is helping you. Then the last one is they will have one of the backgrounds of either asthma or cystic fibrosis. All those ones will help you nail that diagnosis. And by the time you are giving antibiotics, they will not respond. You're having a very serious fever and you are giving antibiotics, it is not responding. You know that that is not likely to be a bacterial contamination, but a fungal infection from aspergillus. Did you get that, Dr. Juliet?
Yes, it doesn't respond to antibiotic.
It doesn't. It doesn't. Okay. So the next one is the Cryptococcus neoformans. So they test this guy a lot. The clincher that I took to the exam, and I'm very happy for Cryptococcus is what? Presence of a narrow budding. So once you see that, your diagnosis is Cryptococcus neoformans. So which one has a broad budding?
Blastomycosis.
Blastomycosis. Narrow budding. Cryptococcus neoformans. That's how you kind of compartmentalize all those differentiating features. So a narrow budding Cryptococcus, that's all you need. Once you see that, you know that okay, this is likely to be. But what are the other things that can help you? It is heavily encapsulated. We've said that. It has a very cheap capsule. It has a very cheap
Yes.
capsule.
India ink.
Indian ink capsule. So if you stain it with your Indian ink, you are going to see that clear halo because of that capsule. It's going to highlight that capsule as a clear halo. Then you can also appreciate the capsule with your mucicamine staining, which is going to appear red. So I think we have it here. We have the Indian ink. You can see the Indian ink here, you know, highlighting the capsular region. Then we can see the capsule also appearing like red, here. This is a mucicamine stain. So red coloration for mucicamine, while we have the white appearance for clear halo that looks whitish for Indian ink. So once you see this chocolate background, you already know what they are talking about, Jerry. You make your diagnosis straight up that this is Cryptococcus neoformans. So those guys are the clincher. So you see your narrow base budding, heavy encapsulation is not dimorphic. So the only organisms that are dimorphic are those four guys that we have talked about, the systemic mycosis. Those four guys, they are dimorphic. Candida is dimorphic. Then you had Sporotrichs skenki. Those are the six organisms that are dimorphic. Sporotrichs skenki, Candidial, and those four guys, those blastomycosis of a thing, those guys, they are the six. The other ones, they are not dimorphic. So if you do your periodic acid sniff test, you can see it too. How did they get it? It's actually from pigeon. So birds dropping in the soil. So the bird they are dropping within the soil. It contains this Cryptococcus neoformans spores. They can inhale it. Then it can disseminate hematogenously to the brain. That is why the most common presentation for Cryptococcus that they will put in the question will be related to meningitis. It will most commonly it will be related to meningitis. but you want to calm down because you know that the blastomycosis, the coccidioidomycosis, they can all cause meningitis too. So you want to look at the clinchers that can help you make your diagnosis. So you can also do a latex agglutination test to detect the polysaccharide capsule antigen. Yeah. So the basis of this test is that you are just adding antibody to the latex. Then you are adding it to the specimen that you are dealing with, maybe from the lungs. You are taking an aspirate from the lungs or maybe any tissue. Then you add it through the latex containing the antibody to the um, polysaccharide antigen of cryptococcus. It's going to agglutinate if that sputum is containing Cryptococcus neoformans. Yeah. So I'm sure you guys are not surprised that we are talking about sputum because we've said it that you get it through inhalation of the spores. So if they inhale the spore, they can have a pneumonia from there. It can disseminate into the blood and cause the meningitis. So that's cryptococcosis for you. It can cause meningitis, which can be complicated with encephalitis. And it can also cause pneumonia, which is even the normal stuff that it causes. And that presentation of the meningitis and encephalitis is very common in people that are immunocompromised. One of those things you can see in the question is soap bubble lesion. I think I've seen it in the question before. So soap bubble lesion. Soap bubble lesion just means formation of gelatinous cystic spaces within the lung parenchyma. So within the brain parenchyma. So they form these gelatinous cystic spaces that coalesce together and they have this soap bubble appearance on your imaging. So you are thinking of cryptococcus. Don't get carried away. What are the clinchers for your cryptococcus? You are looking for narrow buzz bedding, your thick capsule, the stains, Indian ink, and a mucicamine stain. Those guys. Then lastly,
The latex,
exactly,
the
the latest agglutination test. Yeah,
agglutinate.
exactly. Which is the most sensitive and specific. It is the most sensitive and specific. Your latest agglutination test. The most sensitive and specific test you can do. It's very unlikely for them to ask us that kind of question in step one. Maybe step two, but step one, no. It's very no. They don't typically ask all these sensitive. No, 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 no. So just know that it can cause pneumonia because you take it through the airway, then it can disseminate to cause meningitis and encephalitis. So you have to pay attention to this treatment. They ask it a lot. Treatment modality for Cryptococcus neoformans. It can cause a systemic infection. Mm. So particularly in people with meningitis now, you want to start with amphotericin B because we've said it. Amphotericin B is for systemic severe infection. Then you add flutocitozine to that. Um, the way amphotericin B works is just to make holes within the sterile walls of the fungi. So they have this ergosterol wall. So it makes holes within those walls and make them porous. So the cell can eventually die when all the fluid has escaped. The cellular content has escaped through the spores. They will die. That's the way amphotericin B works. That's the way nystatin works. Both of them, similar mechanism of action. They make pores within the ergosterol, you know, membrane. So the cell membrane contains steroid, which is ergosterol, that amphotericin B and nystatin can be. And we've talked about nystatin predominantly for oral lesions. Predominantly for oral lesions. Fluocytosine helps to inhibit the formation of the nucleic acid. So the RNA, the DNA is being inhibited by this guy because fluocytosine can form 5-fluorouracil. So once it forms the 5-fluorouracil, it will disrupt the proliferation of the DNA as well as the RNA synthesis. These two combination, particularly people with cryptococcal meningitis, you want to add fluconazole to it. So they commonly ask this thing a lot. You have amphotericin B plus flutocitozine with addition of fluconazole because fluconazole has a very high CNS penetration. So it can help you take care of cryptococcal meningitis. So don't forget the AFF, I don't know, FFA, I don't know which one we are going to use, but we must already remember amphotericin B first, plus the fluocytosine. Then you had fluconazole because fluconazole has very high CNS presentation.
Okay.
All right. The last one for the opportunistic fungal infection is the mucor and rhizopus. So All these guys happen occur in people that are immunosuppressed. That's why we are calling them opportunistic. There have to be some immunosuppression before they can thrive. So, um, how does it appear? Irregular, broad, non-septate. So this one compared to um aspergillus, it is non-septate. Aspergillus is septate. It has septate hyphae, but this one doesn't have, branching. It doesn't have septa, rather, not branching now. Septa within the hyphae, and doesn't branch at 45 degree. Just branch at wide angles. Just see like maybe two branches like this. One here, the other one here. So this binding at wide angle. So this is more than 45 degree. So this is the way to look at it. You can see that there's no septa here. All the walls they are clean, they are straight. There's no septa in between. You know, once you see this,
Yeah.
this is your rhizopus or your mucor. So these guys, they are wider. You can see that they are wider compared to aspergillus that is just tiny. You can see these
Yes.
ones are wider. So they are wider. They don't have any septa in between, like this line. You'll be seeing some horizontal line. There are no horizontal line in between. Those are septa, and it branches as a wide angle. So that's how you can make diagnosis of a rhizopus. So what do they cause? They cause mucormycosis. So they cause mucormycosis, rhinocerebral mucormycosis, predominantly in people that are diabetic or people that are neutropenic. You see, this rhinocerebral mucormycosis is one of the diabetic defining illness. Most of the time, if you see somebody having rhinocerebral mucormycosis, it's likely there's a 90% chance that the person is diabetic.
So, Dr. did you say rhinocerebral? Is that what you're saying?
Yeah, rhinocerebral, rhino, the nose.
Okay, rhino, like RHI.
Yeah, yeah,
Okay.
yeah. Rhinocerebral mucormycosis. Rhinocerebral mucormycosis. Why do we call them that? It's because the infection starts in the nose. It starts in the nasal cavity and the sinuses. That's where they begin. So what they
Okay.
do is that they start, at that region, they proliferate, they have this branching hyphae. Those branching hyphae are going to occlude the blood vessels in that area. Now, when they occlude the blood vessels in that area, they are going to limit flow of blood. And at the end of the day, there's going to be gangrene of that area. So there's going to be clot formation that will lead to eventual gangrene and necrosis of the tissues around there.
Dr.
So one of the
I don't know what you're talking about. Me, I cannot hear you.
okay, what about now? Can you hear me now?
I can hear you now.
Okay. So I said that um this infection starts within the nose and the nasal cavity.
Mm-hmm.
Did you get that, Dr. Zulia? So the nose
Yes,
and
I
the
got
nasal
the nose. That's what you said.
the nose and the sinus rather, the nose and the sinuses. So they proliferate there. What do they do? They will invade into the blood vessels there. When they invade into the blood vessels there, it's going to cause, because of the fact that they have branching filament, they are going to occlude the blood vessels, and they are going to stop the flow of blood to the tissues around that area, leading to necrosis.
Okay.
So that is why you can see this presentation. Can you see this necrotic tissue that is found here? Yeah. So
Yeah.
this is one way they will have, you have those necrotic tissue found within the nose, and it also affect the eye. It also affect the eye. You can see. Yeah. So the problem has already started. The problem has already started. So because of this, they are going to have facial pain. They are going to have facial pain, and they are going to have formation of this blackish necrotic scar on the face because of the necrosis from the occlusion of the blood vessels. So what did they do next? They find their way through the nose. They get to the cribriform plate. I know that the cribriform plate, that's where you have origination of these olfactory nerves, right, Dr. Zuliat? You know that, you remember?
Yeah. Yeah.
So they can travel from the cribriform plate to the olfactory nerve. You remember the olfactory nerve is just located beneath the forebrain. Do you remember that nerve
Yes.
that just runs beneath the forebrain like this? That's your olfactory nerve. So from there, they can get to the brain. They can affect the frontal lobe and cause frontal lobe abscess. They can come from frontal lobe abscess. So they spread from the nasal cavity, sinus cavity to the eye, causing eye problems to the eye, blurry vision, necrotic tissue within the eye. And because of the fact that the facial veins drains into the cavernous sinuses. We've talked about that when we are talking about acute rhinosinusitis. Do you remember when we were saying that in is it respiratory now? They were talking about acute rhinosinusitis. One of the complications, cavernous sinus thrombosis. Do you remember?
Yeah, yeah, I think so. Yeah.
Exactly. So there's affectation of the eye. So the facial veins they drain into the cavernous sinus through the superior your ophthalmic vein. So they will enter into cavernous sinus. And because of the fact that there's tendency of the necrotic material, um the inflammatory tissue, find its way into the blood vessel, they can occlude the cavernous sinus and they can lead to cavernous sinus thrombosis. I know that the way they will present. They will have headache, they will have proptosis, they can have cranial nerve affectation because you have your abducent nerve, your oculomotor nerve, your trochlear nerve running alongside with your cavernous sinus. So, because of this thing, they start from the nasal cavity, the sinuses, they get to the eye, they have facial pain, they have um, black necrotic ischia in the face. From there, they can spread from the nose also to the brain, to the olfactory nerve. They form a frontal lobe abscess. Headache begins, and you have your full rhinocerebral mucormycosis. So, what do you want to do for these guys? You want to watch out for DKA or neutropenia. We said that. So, neutropenia commonly comes from leukemia. So, there's a leukemia somewhere, or there's a diabetic problem, most commonly DKA. So it's very common in people that are diabetic. Don't forget. Don't ever forget this stuff. Renal
Diabetic,
cerebral mucormycosis is very common in people that are diabetic, people that have DKA,
diabetic,
or people that are neutropenic. Just like
neutropenia.
just like people with neutropenia having disseminated or invasive aspergillosis, you know, or invasive candida. So people with neutropenia can have invasive candidiasis or disseminated candidiasis. They can also have rhinocerebral mucormycosis. So what is the first sorry, I think I forgot to mention something when we're talking about aspergillus. Yeah, I forgot to talk about the treatment. So the treatment for aspergillus infection, the first thing is voriconazole. It is voriconazole. That's the first line to treat aspergillus infection. Then you can use your
Can you
echinocandin.
spell it Borikunazo? Can you just, is it the F or V or
V.
what?
Can you see the screen? It's on my screen. Voriconazole.
Okay. Okay.
Voriconazole. Voriconazole. You can see it. Then you can use echinocandin. Yeah. Always remember that. Voriconazole for aspergillosis. Voriconazole. Voriconazole. It's very unlikely that they will ask. It's very unlikely. So, how do you want to treat this rhizopus infection? You need to debride those necrotic area. Remove them. So you do a surgical debridement because it's very bad. Then you give your amphotericin B or ishavuconazole. Ishavuconazole of amphotericin B. If you remember your amphotericin B, you are okay. Amphotericin B and surgical debridement. They rarely ask about the treatment. They rarely ask. Just know the way they present. Penetrate the cribriform plate of olfactory nerve to enter the forebrain, cause frontal lobe abscess. Yeah. Okay. Then the last one. Okay, not the last. That's still pneumocystic girovecti. So pneumocystic girovecti can cause pneumocystic pneumonia. We call it PCP. So it's one of those diseases that you find in people that have AIDS. Very, very important. So it's a yeast-like fungus. So this is a yeast actually. Yeah. So we don't expect this one to be having hyphae unless it is candida. It is a yeast, not a mold. So it exists as a yeast. So majority of people have this infection. Some people have this infection, but they are asymptomatic. Once they are immunocompetent, they'll be asymptomatic. But once they become immunosuppressed, they start developing the features of pneumocystic girovecti. So pneumocystic girovecti is one of the causes of atypical pneumonia. So you can have this slowly progressive pulmonary symptoms like cough, dyspnea, chest pain, and there's going to be a background immunosuppression definitely, like HIV/AIDS is going to be there. What do you see on the X-ray? So X-ray is not very high. You are going to see this diffuse opacity, just like what you have for your atypical pneumonia. Diffuse, uh, opacity. But your CT can actually help you. You can see the opacity here is diffuse, affecting this entire area. Then there's this affected. There's this side too being affected. So you can see it's diffuse. Yeah. And the CT will actually help you. It's more clearer. You are going to see the ground glass opacity. So this ground glass opacity is not even very prominent here. It's very conspicuous in the previous first day, the 2022. Yeah. Alongside with the ground glass opacity, this whitish tone that you are seeing, so that's the ground glass opacity. You are going to see nematocysts. So nematocysts are just like cavities that contain gas. So we can see this black stuff. Can we appreciate them? These black areas here, openings.
Mhm.
Those are the nematocysts. So once we are seeing bilateral affectation of the lungs, bilateral, we are thinking of an atypical infection, because you know that the normal lobar will just be one side, one lobe. They are usually unilateral. But you're having a bilateral problem, it's likely to be an atypical cause. So you continue with the history with the background immunosuppression. They are guiding you to pneumocystic. What's the immunosuppression? 8 again. That's likely to be pneumocystic. And of course, they are going to tell you the laboratory finding that can help you nail that diagnosis. So because it can cause pneumonia, if they cannot produce sputum, you want to do a lung wash. So by doing a bronchoalveolar lavage, or you go in, you take a biopsy. Whichever one is convenient. But I think bronchoalveolar lavage is easier than taking a biopsy. So what are we going to see? We are going to see disc-shaped yeast with our methanamine silver stain. So we said it, methanamine silver stain works for fungi. So we said that fungi is the first thing that will come to our mind whenever we see the methanamine silver stain. So it's just going to appear like a disc, like these are the these are the um, organisms, these are the yeast of this pneumocystis that we are seeing here. So this shape, once you are seeing it like that, you know that okay, this is likely to be pneumocystis that they are talking about. Or we can use our
So,
fluorescent antibody. So they are going to describe it even for us in the question. So this shape yeast on using this special stain, methanamine silver stain, you are taking a pneumocystic derivative. So what I just want you guys to always do is that just try to recall, ask yourself, what are the findings that I can use to pin any of these guys? Once you're able to say them, it stays with you for life. You already know what you want to say for your cryptococcus. You already know what you want to see for your blastomycosis. You know what you see for candida. You know for aspergillus. You know for hemocystic. Hemocystic disc-shaped yeast. It's a yeast-like fungus. It used to be. They used to. They were actually confused. It was a protozoa or the fungus, but it's actually a fungus. So disc-shaped yeast with methanamine silver stain. You know that's our pneumocystic. Or you can use fluorescent antibody. That one is not very. They will rarely tell you that. They will tell you this thing more than the fluorescent antibody. So how do you want to treat it? You can use Septrin. So trimethoprim, sulfamethoxazole. You can remove this sulfamethoxazole, replace it with um Dapsone. So okay, yeah. So you can combine TMP with Dapsone, or you can use pentamidine. So you can use your Septrin. You can combine your trimethoprim with your Dapsone, or you can use pentamidine. You can even use atovaquinone. So this atovaquinone is one of those medications that you can also use someone that has malaria. So you can use it too in someone that has a pneumocystic. So Septrin is the first one, pentamidine is another one, then Dapsone can replace SMX, and you can use it. So you can use that Dapsone actually like a single agent. For example, if you want to give a prophylaxis, so you can use Dapsone only. But if you want to use it as a treatment, you have to combine that Dapsone with TMP, or you can use atopic. So once the CD4 count is less than 200 in people that are having HIV/AIDS, you want to start prophylaxis for pneumocystic derivative because it will almost always affect them. So you can use any of the agents that you are using to treat to also do the prophylaxis. So, but if you are using Dapsone, you might not need to combine it with SMX. You might not need to combine it with TMP. So just give Dapsone only as a prophylactic agent. You are fine. So once you remember the treatment, you remember the prophylactic agent. Your Septrin, pentamidine, Dapsone, atovaquone. Anyone you remember. Yeah. So Sporotrix skenki. This is the last dimorphic fungi that we talked about. So it causes sporotrichosis. It's a dimorphic fungi. It is cigar shaped. So this one is cigar shaped yeast um, at 37 degrees Celsius. So in the human body, it exists as mold with hyphae. Sorry, I said human body. In the environment, in the soil, it exists as mold with hyphae. You can see that it has a hyphae with spores in the soil. While in human, it's changed back to the yeast form and it's cigar shaped. Unlike the yeast of pneumocystic that is disc shaped. Sporotrix skenki yeast is cigar shaped. So you find this mold form of Sporotrix skenki on some plants, some vegetation, particularly rose flower. That's where it thrives. So all these rose gardeners, these farmers that are planting those rose flowers can easily get um, infected with this Sporotrix because once that rose flower kind of scratch their skin, once there's a trauma from the flower on the skin, you can introduce the spores into that traumatic area in the skin. Then your organism starts proliferating in that area and it starts causing problem. So the Sporotrix skenki can cause erythema at that area and just develop into an erythema or ulcer at that area. So that is cutaneous sporotrichosis. One thing about this infection is that once it starts at one area of the skin, it can disseminate, it can travel through other area, but it kind of follows the path of the lymphatics. Once you are seeing that in the question, you know that that is Sporotrix skenki. So once they tell you that, okay, following injury from
Don't get
rose,
Dr. Babawale, so you were breaking. You said once it starts in one area of the skin, what happened?
yeah, it can
Hello?
spread to other area along the lymphatic. So it will follow the course of the lymphatic. Do you
Okay.
get it? So the course of the lymphatic
Okay.
is how it's going to travel. So it's going to be affecting the overlying skin over those lymphatic area. So we call that the lymphocutaneous form. So to affect both the lymphatic and the skin over there, you know, as a lymphocutaneous form of Sporotrix skenki. In some individuals, it can disseminate. So people that are immunosuppressed, you can have a disseminated form of Sporotrix. It can go to the brain commonly, it goes to the joint, it can go to the spinal cord and cause problems there. How do you want to treat this guy? You give potassium iodide and itraconazole. So itraconazole and potassium iodide is what we use to treat it, especially for the cutaneous and the lymphocutaneous one. For the immunocompromised host, you want to make sure you control the viral load first. Bring it to, you know, a high state because it's unlikely that your itraconazole or your potassium iodide will work against it. So don't forget, you have the um, rose trauma on the skin, inoculating the organism at that site. It travels through the lymphatic, affecting the lymphatic, causing lymphangitis as well as ulcers on the overlying skin, and that's the lymphocutaneous form. Then it can disseminate. You can see this one now. You can see here, it's like moving like that. So there's one here, there's one here, there's one here. Most likely there's a lymphatic drainage along this route. Do you get it, Dr. Zuliak? So
Mm-hmm.
yeah, so that's the way it works. So that's one thing we want to pay attention to. Do we have others here? Dr. Abisola, are we there? Because it's only Dr. Zuliat
Yeah,
present.
yeah.
It's only Dr.
I'm
Zuliat
here.
we are hearing since morning. Okay.
Yeah, yeah.
All right. That's good. So we are done with the fungi, guys. That's all about the fungi. That means that if we see any question on fungi by now, we should be able to tear any question on fungi. I trust you guys um on that because it's not too much and it's very straightforward. That's why I like those fungi. They are very straightforward and they are not too much, unlike the bacteria. So protozoa. So I don't want you guys to actually worry much about the medication. They will not ask you. It's very rare for them, no medication. I've not really seen any question on medication like that. It's more of making the diagnosis. That's the major focus. So the protozoa. These protozoa guys are being classified based on the system that they affect. So the gastrointestinal ones, the central nervous system ones, you know, that's the way it was classified. So the ones that affect the gastrointestinal tract, the ones that affect the CNS. Yeah. So what are the ones that affect the gastrointestinal tract? There are three: Giardia lamblia, Entamoeba histolytica, and Cryptosporidium. So I know we are familiar with some of them. Yeah. So Giardia lamblia is a protozoa that affects the gastrointestinal tract. How we are going to be very fast here. Just need the clinchers and we move. That's all. So how do we get Giardia lamblia? We take the cyst in water, so it's like fecal round. So fecal matter that is containing the cyst, you know, the person takes the water, you take in the cyst will travel downwards into the GI. When it gets to the small intestine, they are going to change back to the trophozoite. Hello?
What's your infection?
Hello? Hello?
Hello, Dr. Babali. Hello.
Yes, I'm listening, Dr. Juliet. Are you there?
So yes, we are here. So the only part that we heard since morning was that they are based on where they infect, and you said gastrointestinal and the CNS, and then that was all. In fact, it was only gastrointestinal. You said.
Oh my god. Yeah. So the gastrointestinal infection. So I said three organisms: Giardia lamblia, Entamoeba histolytica, and Cryptosporidium. So Giardia lamblia will cause giardiasis. So I said that we are just going to be very fast. Can you guys hear me now? Can you guys hear me now? Hello? Dr. Zuliat, are you guys there?
Yes, we
Yes.
can.
Yes.
Okay, thank you. Thank you, Dr. Abisola. Yeah, so I just want us to round up with the the CNS one so that we can move. Hmm? So how do you get Giardia lamblia infection? Someone takes the cyst in water. So this cyst is being shed from someone that has giardiasis. So if someone has Giardia infection, they pass out the cyst from the stool, it finds its way to the water bodies like food or the other source. The person takes it in. So if the person drinks water that is containing the cyst, it will move down through the GI. When it gets to the small intestine, it will change to the trophozoite. This trophozoite is the infective form that kind of cause the infection. Very important. So it's the one that will cause infection in the small intestine. What did these guys do? What they just do is just to blunt the enzymes that are located within the villi of the small intestine. And you guys remember the enzymes include our peptidase, the enteropeptidase, lipase, and all those things. So, but
Mhm.
particularly if there's problem with the peptidase, they cannot absorb amino acid. They just be suffering from malnutrition, protein energy malnutrition. That's just what it's going to be. But the one that will be evident, the one that's going to be very evident is when there's problem with the lipase. So when the lipase cannot digest fat, there's going to be fatty diarrhea or steatorrhea. So that is why people with Giardia lamblia have steatorrhea. So you don't need to be thinking of watery diarrhea or dysentery. What you want to have at the back of your mind is steatorrhea or fatty diarrhea. Once you see that, you know that they are likely talking about Giardia, because the mechanism of action of Giardia causing problem differs from the other ones. It blunts those enzymes, those villous surface that contain the enzymes. They cannot digest fat in the stool and they cannot absorb it. So they are going to have foul smelling stool. You guys know someone that has steatorrhea is normal, is going to be foul smelling. I don't know why. Maybe because of the fatty acid chain that's been metabolized there, that causes the foul smelling issues. You guys remember that the anaerobe, they also metabolize. Okay, have we talked about it? I think we've talked about the anaerobes metabolizing the long chain fatty acid, producing, some gases, which is very foul smelling. Yeah. Same thing happens here. The fatty acid are being broken down, which causes the foul smell as shared with giardiasis. It brings about the flatulence. So there's a lot of gas. Flatulence, there's bloating, and there's steatorrhea. And it is non-bloody. Your answer is Giardia lamblia. And we said it that it's also one of those problems that can happen in people that are traveling. So although we said the commonest cause of travelers diarrhea is what? Anybody?
Toxigenic something.
Exactly. I'm very happy. When you guys are giving me stuff like that, spinal, I'm very happy. Like everybody's happy. E-tech, heterotoxic. So the same thing for this Gardia too. It's also one of those travelers diarrhea. But it's not as common as but what you are looking out for is steatorrhea, flatulence, bloating, um, non-bloody nature and steatorrhea. They get it from cyst. So what you see, you can see the trophozoites and the cyst in stool when you do your microscopy. What do you want to use to treat? Remember metronidazole, first line. Metronidazole, tinidazole is also a form of, is also a drug in the metronidazole class. So you can use tinidazole, you can use metronidazole, you can use nitazoxanide. So nitazoxanide is also one drug that you can use to treat cryptosporidium. So it's good to actually know it. It's good because once you know the nitazoxanide now, you can know it for the treatment of cryptosporidium too. So that's why I feel that we should know it. Nitazoxanide. But the first line that they commonly use is metro or tinidazole. Yeah. So how will you identify the trophozoite? The trophozoite of Gardia resembles the trophozoite of Trichomonas. It is pear-shaped and it's also flagellated. That's it. But the cyst, let's look at the cyst. We have to look at that image to remember it. So it has like a thick wall, the cyst. This is cyst. They don't change this image. Hey, but this is the trophozoite. So you can see that it's like looking like a pear and it is flagellated. So once you are seeing this, and you are not seeing discharge, you are thinking of what? Gardiasis. But if you are seeing something that looks like this and you are seeing greenish discharge, what are we thinking of?
Greenish discharge.
Mm-hmm. What organism causes green discharge? I've talked about.
Maybe Pseudomonas, all those pyocyanidin.
Ah, greenish vaginal discharge. That's what I mean. Oh.
Oh,
Trichomonas.
Trichomonasis. I'm sorry.
Trichomonas.
I'm sorry. I didn't give you guys the right information, but I thought I said it that both of them, both the Trichomonas and the Gardial trophozoite, they appear pear-shaped. Both of them are pear-shaped and they are flagellated. Yeah. So, but you know that you see that one on wet mouth of maybe discharge of vagina. But this one is true. Don't forget that. So, tinidazole, metronidazole, nitazoxanide. Yeah. The next one is entamoeba histolytica. This one is a very bad guy. Very, very bad guy. Amoebasis. Amoebasis. Now, um, amoebasis typically causes dysentery. We don't need to go into the details. You also take it like the cyst of Gardia. It's also taken through the cyst, in infected water. So you take the water that contains the cyst, gets to the GI. But this one, unlike Gardia that affects, so which area do we say Gardia is affecting? Which area of the GI is Gardia affecting?
See, miss out brain, right?
Hmm? Which one is the area that absorb all those things? Fat and the area and the other things too.
That's the ileum.
Yeah, so
Wait,
that's like the small intestine. So that's the way to remember it. Those are the one that contains the enzymes. Hmm? Guys, am I too fast?
No.
Because I'm surprised though. Hmm? We should remember it
Your
though. Hello? Dr.
is your
Abisola? Dr.
I
Abisola?
said oh Dr. Babali.
You said what?
It is your network.
Okay, you answered it, Abi.
Yes.
Okay, I'm happy. Well done. So, the small intestine, those are the one that contains those villi stuff. The villi of the small intestine contains those enzymes, including your enteropeptidase, the lipase that helps to digest. So, Gardia is majorly small intestine. Unlike entamoeba histolytica, this one is large intestine. You go for the large guys. That's where now I'm trying to talk like Dr. Babarinji now. So it goes for the large guys and destroy the mucosa of the large intestine. So it's highly very invasive. So it erodes into the um um now the pathophysiology of entamoeba is very long, but we don't need it. We don't need it. So what it does is just to invade into the epithelial cells as well as the blood vessels within the large intestine. The when it erodes into the blood vessels, that is the trophozoite. So guys, we said it that it is the trophozoite that is the infective form. That's the one that is causing the damage. But the one that helps you to introduce the organism into the host is the cyst form. So the cyst form, when it gets to the host, it will transform into the trophozoite. The trophozoite is the one that will now start burrowing into the epithelial cells and the mucosa, the blood vessels, causing the problem. It burrows into the blood vessels, invades into them, engulf the cells that are there. It will engulf the white blood cells, lyse the white blood cells. Once it lyses the white blood cells, the lytic enzymes within the white blood cells will now be released into the environment, and that will further digest the tissue within the intestine. So it's going to engulf the red blood cell and it will keep them. So it's like red blood cell heater. Very important. Very important for the diagnosis. So through all this mechanism is going to cause bloody diarrhea. So it's going to cause a diarrhea that's going to be bloody. So that is why entamoeba histolytica is a cause of dysentery. Please, we must remember.
Dr. Bobawale, you said two things. You said it engulfs white blood cell and releases like the cytokines that damages the colon further, and then you said it engulfs RBC.
Yeah.
The two is what you said, right? Okay.
Exactly. But it will lyse that white blood cell. It will lyse the white blood cell. So it's when it lyses the white blood cell that the digestive enzymes in the white blood cell that they used to even damage cells normally will now be released, which will now further damage the colon mucosa. Do you get that, Dr. Sylvia?
Yes.
But the red blood cells are kept within them. They just engulf it. Now, that's the mechanism by which it can cause blood diarrhea. It can also find its way into the bloodstream, especially in the disseminated form. It will find its way, or the invasive form. So it will find its way into the bloodstream, enter the portal vein, and it cause liver abscess. Entamoeba histolytica is one of the cause of liver abscess. So once we have ruled out Entamoeba histolytica, you can be thinking of Echinococcus granulosus. Very, very important. Then before we now start thinking of staph aureus that those guys gave us that day, don't mind them. You only see that one once in a while. Most of the questions they will be putting, liver abscess to make diagnosis of entamoeba histolytica. Yeah. So because of the liver abscess, they can have a right upper quadrant pain. So once you are seeing right upper quadrant pain and you can see an abscess, maybe on your imaging ultrasound, that's likely to be amoebasis you are dealing with, and the person is having diarrhea that is bloody. You see these three symptoms there. They will be there in the history, live and direct. Bloody diarrhea after the person has traveled to an endemic region, right upper quadrant pain, and you can see the abscess maybe on imaging. Yeah. So if you do the histology of the colon that's affected, you are going to see flax-shaped ulcers. Very important. Transverse ulcer for tuberculosis, horizontal ulcers, for typhoid, flax-shaped ulcers for entamoeba histolytica. That one is very easy to palm. So this is the way the flag-shaped ulcers will be. Can we see this? Like a flask. You can see that there's an opening entering into the base below. Did you get that, guys?
Yes.
So if you have a transverse ulcer, it's likely to be tuberculosis. We have like a vertical ulcer. Vertically, sorry. I said horizontal the other time.
You said horizontal the other time.
I'm wrong, sorry. But horizontal and transverse, they are the same thing. So a vertical
Okay, so
ulcer.
vertical is for typhoid or
Typhoid, yeah. Transverse tuberculosis. Flagship, our brother of entamoeba histolytica. So how do you do it? You can do your serology PCR. Forget about that, guys. The most important thing here is seeing the trophozoites that are engulfed with the RBCs. So this is what we are going to see. So once you see this, red blood cell, within the trophozoite, this is entamoeba histolytica. They'll put it in the history. They did, the microscopy, and they were seeing trophozoites. Microscopy of these two trophozoites containing red blood cells. That is entamoeba histolytica. You are going to see the cyst containing multiple nuclei as high as 4, but this one has 2. So this is how the cysts look like. You can see the cyst of Giardia cyst, thick wall. but this one has like conspicuous nuclei, like circular shape. The anti-mobile histolytical. Don't forget the flag shape also. Now, how do you
Sorry,
want to?
doctor. Doctor, I did not really get the nuclei differentiation that you were differentiating. You said that the cyst of the entomopathy has like is transparent or something and has four
No, I said
nuclei.
it's
Is that what you're
conspicuous. I
saying?
said it's conspicuous. You can see this nuclei like this. This true.
Conspicuous.
You can see these guys like here. This true nuclei
Okay.
here. Yeah, these are the nuclei. Yeah. So I'm trying to compare with the cyst of Gardiasis. You can see that the cyst of Gardiasis is like thick wall here. You can see this.
Okay.
You-
Okay.
Then this one has the nuclei that is showing. Yeah. And you can see the red blood cells within the trophozoite here. You can see it.
Yes.
Yeah. Okay. So the mainstay now, let me pause here.
Just go and sit there and
You
be
get
concentrated in that area.
to just go and sit there and concentrate in the area. So metronidazole is to kill the trophozoite so that you stop any invasive form of amoebasis, the one that's causing liver abscess, blood diarrhea. While your paromycin is a drug that is not absorbed within the intestinal lumen. So once you take it orally, it stays within the intestinal lumen and it kills the cysts that are within the intestinal lumen, preventing the cyst from being shed out as a carrier state or the cyst from being differentiating into the trophozoite to cause um, invasive disease. So most of the time you want to combine both of them, metro and your paromycin. So to replace paromycin, they can use the iodoquinone. Don't forget that. Cryptosporidium is the last one. I think that's where we are going to stop. Yeah. So cryptosporidium can cause severe diarrhea in people that have HIV/AIDS. Yeah. So once you see severe diarrhea, someone that's having AIDS, and you do the gram stain, you're able to see acid fast organism. These oocysts are having their acid fast. You know that is likely to be cryptosporidium. Most of the
Hmm.
time, you know that avium too can present that way, but avium will still be having pulmonary complication. Do you get it?
Application.
Yeah. So with the diarrhea,
Mm-hmm.
you can see pulmonary complication. But if it's strictly diarrhea that is watery, that is watery, that is cryptosporidium causing, and it's very recurrent in people that have HIV. It's very recurrent. People that are immunocompetent can also have it, but it's self-limiting. It will go. It's very mild. It will go. So it's the oocyst, not the cyst. Oocyst now that they are taking in. So the oocyst will differentiate and cause a problem. So the treatment is by giving the nitazoxanide, just like what we are giving for Gardia. Nitazoxanide can help for cryptosporidium. So you don't need to treat people that are immunocompetent because it's self-limiting. Just make sure that you are filtering the water so that it's free of the oocysts. So once you see diarrhea in 8, one of those powerful differential, cryptosporidium. And you know that once you do the gram stain, the acid fast stain, the Xenesi stain is going to be acid fast. I think this we can see the acid fast stain.
All right. So
See
basically, we do the acid fast.
the acid fast stain, you can see it. Yeah. Okay.